Hello YouTube. I am starting to exhibit a lot of symptoms that I'm familiar with in treating TMD patients. I thought it would be interesting to kind of just chronicle some of what I'm feeling all the way through treatment and after treatment follow-ups, just kind of as an educational way to reach others that are suffering in an attempt to educate and just kind of share some information. So how long has this been going on with me? Well, first of all, a little background on me. I've been treating TMD for 15 years, 14 years, something like that. And I'm known for employing various technologies to get the end result that I want and try to help patients in the best manner that I know possible. And so I've seen a number of different paradigms and protocols in order to make patients better and how to treat and how to diagnose. And for me personally, I think I should get a pass, but life doesn't work out that way. So what is bothering me? What are my symptoms? So probably about 3 months ago, I started having issues in my neck, specifically around my tongue. When I would yawn and swallow and chew food, it would hurt, specifically on the right side. And talking didn't seem to affect it too much, but only when the muscle had to exert force, like in a swallow or chewing, moving the food around in my mouth, and it would affect all the way down to here. The SCM was involved for sure. My shoulders and neck feel tight. Teeth are sensitive to cold, and probably the biggest things are headaches kind of around the eye. I wouldn't say they were migraine type. Certainly I've seen people suffer a lot worse than me, but around the eye and back over in this area here, and then the sides of my face, both sides of my face, and the headaches are kind of behind the eye and up in the front, this frontal area here. No really back headaches in the occiput region. Side headaches not too much, but tension for sure. So what are my treatment options? So number one, do nothing, but since I'm making this video, I think it's safe to assume that I want something done about it because it seems like it's ramping up. I could undergo ortho, move the teeth to be in a position that was orthodontically stable, if that was a concern. The aesthetics are not. Also, I've had ortho once. Not a big fan of having it a second time. It wasn't that pleasant an experience the first time. I could build myself a appliance of sorts, an acrylic appliance, whether it's a flat plain Michigan splint where we could the teeth could be allowed to move all over the place that they wanted, or an anatomic splint which would pick the most neutral position for the jaw and then dial that in. I could do an NTI appliance, which is just an appliance where it touches only in the front and keeps the back teeth from touching. I could do, let's see, those would kind of be first phase one type treatments to see if the symptoms were part of a bite issue or a jaw issue. And that would be part of a diagnostic workup would be, if that works, well, we'll just move everything to that position, right? But I would have to undergo a phase 2 therapy, which would still involve ortho or crowning 28 of my teeth with veneers and case finishing, that type of stuff. Or I could do TruDental. I could do an equilibration. I could do disclusion time reduction therapy. The full mouth rehab could be done in either a CR-based philosophy or a neuromuscular-based philosophy. And so all of those things that I did mention, I've actually trained in how to do and have the equipment for. The only problem is I can't do it on myself because I can't see what I'm doing, obviously. So knowing what I know and having used all of that information to treat patients with TMD, what am I going to select? I'll tell you there's two that I use predominantly in my practice. One is the neuromuscular paradigm, but I usually employ that when there's a skeletal issue, meaning there's a relationship issue between the maxilla and the mandible, and those don't come together, or they're canted and you can't adjust one side like this picture here. Obviously, this is not going to be a enamelplasty type case, but my case is unusual in the sense that it is a unilateral crossbite. So I'm class 1 on the left and class 3 on the right. So of all the cases that I've done, and probably the most fastest of all the therapies is disclusion time reduction, or DTR for short. So about 90% of my cases fall kind of into this paradigm, and if there's a skeletal relationship, I use the neuromuscular. I think what I'm going to do is contact one of my mentors and see if I can't get him to fly out to my office and treat me, and that'll be the next step. So how do I manage this day in and day out, treating patients and kind of making sure that I'm comfortable enough to actually perform? Well, usually do that with Advil. In fact, I'm sitting at my desk right now. Here's ibuprofen, and you can tell this is 500 count, that over the course of, probably the beginning of the year, I've taken quite a few of these, and that's not good for liver, kidneys, or the rest of the body. But sometimes good doctors turn into be bad patients, and it's hard to, since I can't treat myself, and doing what I normally do, there's probably only 4 or 5 people who I would want working on me. One is Robert Kirstein, he's in Boston. Prafula Thumadi in India. Also Vikas Agarwal, also in India. Patrick Jawar, although not DTR certified, certainly is capable. Curtis Westerson is DTR certified, and he's in Canada. But I'm probably going to end up going with the guy who's got the most talent and experience in this one therapy that I prefer to do, to choose that person as a provider to actually treat me.